पाक से।
अल्हम्दुलिल्लाह।
कुल अऊज़ु बिरब्बिन नास मलिकिन नास इलाहिन नास मिन शर्रिल वस्वासिल खन्नास الذي يوسوس في صدور الناس من الجنة والناس।
टीम होगा, सबसे रिक्वेस्ट है कि वो अपनी
ये भी नहीं होएगा।
आज के स्पीकर डॉक्टर शहीद साहब को कि वो स्टेज पर तशरीफ लाएं और आज के लेक्चर का आगाज़ करें।
गूगल पिक्चर सर।
अस्सलाम वालेकुम। सॉरी, थोड़ा सा वो अरेंजमेंट में थोड़ा सा इशू है, वो कर रहे हैं। आवाज़ आ रही है जी पीछे तक? ठीक। आज यहाँ पे जो हमारे लेक्चर जिसके लिए हम इकट्ठे हुए हैं, वी आर गोइंग टू टॉक अबाउट certain advances regarding treatment of certain metabolic conditions। और उसमें जो आज हमारा है मेन आइडिया जो है वो ये है कि हाउ डू वी ट्रांसफॉर्म। ओके ओके, that how we reach this conclusion that using certain medication we can change metabolic profile of a patient, of a person. May I have first slide please? Next slide please. Foremost among the challenges that a doctor faces in any social situations is that how to address this epidemic of obesity in the world. It's such a challenge that we have to take into consideration every aspect and every facet of the condition to address this appropriately. There have been many claims in the past how we address this. But the point remains how to address this in such a safe way that person doesn't get any side effects. Rather, there are pleiotropic effects of the drug which ultimately gives you positive effects on the other organ systems. Next slide please. And next. So what we are going to discuss today, is regarding GLP-1 agonists. आ गया? Great. We are going to discuss GLP-1 agonist and its use in obesity as well as other metabolic conditions. And what are the benefits of it? Controlling the obesity, going beyond glycemic control, and then biosimilar products available in our country now regarding all those GLP-1s which are available internationally, originally which are brand leaders, their biosimilars. And in the end we will have a question answer session. So what's the underlying cause of obesity? Obesity is now, as I already mentioned, it's something like an epidemic now. And to address this various facets, I'll describe certain components which are to be taken into consideration. When a man is obese, we feel that he has either hungry brain or hungry gut. So they are a part of a newer phenotypic guided approach to understanding and treating obesity. Hungry gut, what does it mean? It's a feeling of not getting a fullness after meal. As soon as a person finishes, he feels again hungry within an hour or two. And it is due to faster gastric emptying. This is one concept. That means that food leaves stomach quickly, and that leads to feeling of inadequate fullness. Its symptoms are that there is frequent hunger after meal. खाना खा लिया है, उसके फ़ौरन बाद फिर उसको भूख लगी है, फिर थोड़ी देर के बाद उसको भूख लगी है. He doesn't feel satisfied after taking food, because transit of food through stomach is very quick. It is abnormally fast. What is hungry brain? On the other hand, it's a phenotype in which the person struggles to feel full during a meal, leading to extra consumption of calories to the level that he is uncomfortable in his stomach otherwise. Stomach is overfilled, but his brain is not getting the signals. This is the type in which patient keeps on eating, जिसको हम पेटू कहते हैं, keep on eating without any feeling of any stops in between. So it is because of two things. One is that the person is not getting signals through the vagus nerve. A vagus nerve is dysfunctional. When the stomach is full, the message must go to the brain that we have to stop here, but it won't stop. So what is the take-home message from this? This means these people cannot lose weight if we give them salads or other foods which are very low calorie, because they will keep on eating. Salads basically work through signaling the fullness. The satisfaction is not there. People will keep on eating. So this is hungry brain. So we talk about gut-brain axis. Vagus nerve, which transmits the signal between digestive system and brain. Then neurotransmitters. There are certain chemical messages which are routed through dopamine, serotonin, norepinephrine, which actually influence hunger and satiety. So a patient never attains satiety. This is also related to certain psychological conditions, and it's also related to certain conditions like Prader-Willi syndrome, like all those people in which hypothalamus hunger area is damaged or it's not receiving signals. So these people overeat and they cannot control their weight. What are treatment approaches? First of all, we find which phenotype the person falls in. and then we can treat. There is no treatment for obesity that one size fits all. It's not there. It's not possible. So treatment approaches, one is lifestyle modification, number one and foremost. We have to tell people how to eat, when to eat and when to stop. So mindful eating, that's what we call small portions and stopping before they are feeling full, stopping before that time. This works in certain people. Then we have medications like target this appetite regulation, static pathways. There are some of them, some antidepressants like propionine, like betaine, like topiramate. They all actually work through central nervous system. Whereas final approach is that if you don't have any other way to do it, then you go for bariatric surgery. Bariatric surgery aims to lose weight through directly changing the phenotype, that is removing the fat from the body, and then you reduce the size of stomach and all. And by that, hunger is controlled to a certain extent and the patient loses weight. So current scenario, what is current scenario? What are we facing? What challenges are there? We have people who are living with diabetes, we have people who are living with obesity, and there is an overlap. You see, 17.6 million are living with obesity and 38.2 billion are living with diabetes. An overlap of 14.9 million is there where we have both conditions together. So this is the group where GLP-1 acts best. We get the best results here, where patient is diabetic and obese. If we go on the guidelines, all guidelines now, they start treatment with GLP-1s. Actually, the only drawback, I'll come to that during my presentation, the only drawback is the cost. Otherwise, if you go for cost effectiveness, they are the best. They all start ADA, EASD or IDF. They all start with GLP-1s, and they are recommended in high risk and established cardiovascular disease patients because they actually have pleiotropic effects. They are efficacious for reducing diabetic load on the patient, and they also help in weight reduction, and they have very strong relation in reversing the fatty liver disease, that is MALST. There have been various trials for all these claims. Actually, GLP-1, especially semaglutide, it works on 7 different sites. There are 7 sites on which insulin works, and the sensitivity is increased in all 7 sites with this drug. So your insulin is working better. You require lower dose of insulin to have the job done. So when insulin will be low, insulin is an anabolic agent. So you will have certainly weight loss. All these like weight loss, diabetes, metabolic dysfunction associated steatohepatosis, CLD, CKD and cardiovascular disease. All of these have been proven in various trials. There are 10 trials on weight management. There are 11 trials on diabetes. There are 2 trials on metabolic dysfunction associated liver disease. There are 2 trials on chronic kidney disease, and there are 5 trials on cardiovascular diseases. And all of them provide us ample evidence that this is the best choice to start in a diabetic patient. These are the lists of trials that have been carried out and all have proven benefits. If we talk about significant HbA1c reduction across clinical trials, we see that there is various levels achieved in various trials, but none of them to the insignificant level, 81% to 87% in various trials. It has superior glycemic control. Semaglutide actually reduces HbA1c by minus 2.1% at 40 weeks. As far as weight loss is concerned, as you can see, weight loss starts here and across the board as time increases, there is a significant difference with the controls. It is done with various different parameters with it. Head-to-head trials with metformin, tizanidine, sulfonylurea, metformin, sulfonylurea, insulin and metformin, metformin, sulfonylurea, and so on. So ultimately the sustained trial. Weight reduction in semaglutides in the treatment of obesity is recommended in step 1 to step 8 except for step 4, which is actually regarding cardiovascular disease. Similarly, comparison, it is breakdown of the same slide actually, comparison with various things. As far as cardiovascular disease is concerned, there were 2 trials and both of them confirm that there is a significant difference between mortality in 2 groups, control versus semaglutide, by 6.6%, which is significant, 26% reduction. As far as chronic kidney disease is concerned, there is 24% relative risk reduction in the group which is using semaglutide. As far as the resolution of NASH without worsening the fibrosis, hepatic fibrosis is concerned. So it has been proven that up to in patients with NASH, up to 59% improvement with no worsening of liver fibrosis at all in either of the patients. Despite guidelines, recommendations and benefits beyond glycemic control, approximately 66,000 out of 15 million patients were prescribed GLP-1s. There's a big question why in Pakistan. There's a big question why. Now I'll address the question. Cost. This is the cost. We pay for our drugs in Pakistan. We pay for our medication from our own pocket. So it's very difficult for people to afford such medication. So what do? We have to go on to biosimilar products. So what are biosimilar products? Biosimilar products are biological products which are generally created through genetic engineering of yeast or bacteria or other organisms, and they are related. How they are biosimilar? It is highly similar and has no clinically meaningful difference with existing FDA approved brand leader or the main research product. It should meet additional requirement of a potential for change in safety and efficacy related to switching back and forth between interchangeable products. यानी आप मेन प्रोडक्ट यूज़ कर रहे हैं या बायोसिमिलर प्रोडक्ट यूज़ कर रहे हैं, कोई फ़र्क ना हो दोनों के अंदर. And there should be evidence that it produces the same clinical results as the reference products. So this is the way that we approve a product that it's biosimilar. Go with analytic comparison. First we have non-clinical studies and clinical pharmacology. Then we have comparative clinical studies. Then we go in vitro, that is in lab similar studies. Then we go for phase 1 trials, then clinical studies, and then we go for phase 3 trials. So as far as the specific product of SEMP is concerned, these are the statistics as given. As you can see, there is apparently, as at a glance, there is no major difference. Reference group or test group is same, and there is marginal difference in adverse reaction, which was actually more in cases of the original product. That is something commendable. These are the general side effects that we see, that we come across with these products, though very low, but they are there. And as it is shown here, there are certain people, there are 3 cases of gastritis in the group, which have, as compared to 4 of intestinal obstructions and vitreous hemorrhages. So this is the only biosimilar semaglutide in Pakistan. Now if we have any questions, I am here to take them. I would request lots of questions because I have so much to say.
सीमाग्लूटाइड के जो साइड इफ़ेक्ट्स हैं वो यूजुअली पेशेंट टॉलरेट नहीं करते, वो यूजुअली 1 से 2 वीक तक यूज़ करते हैं और उसके बाद वो कोशिश करते हैं छोड़ दें।
इशू ये है कि सीमाग्लूटाइड स्टार्ट करने के लिए पहले तो पेशेंट सिलेक्शन इज़ फॉरमोस्ट, वेदर द पर्सन रिक्वायर्स इट और नॉट। पहली बात, क्या इस मरीज़ को सीमाग्लूटाइड पे जाना चाहिए या किसी और ड्रग पे जाना चाहिए, फर्स्ट। सेकंड, गुड पेशेंट काउंसलिंग इज़ वेरी इंपॉर्टेंट, because a person who is brain hungry would always love his food. When you tell them that this thing will stop you from eating, initially he will agree, but when you will give him an injection and he cannot eat beyond a certain level, he'll come back to you with this saying, please do something about it. One thing, it usually delays gastric tempting. That is one of the main effects of semaglutide. The person will definitely feel this. The only method is good counseling and then step up approach. You start with very, very low dose and titrate up every 2 weeks. Going before 2 weeks will again have the same problem. Interestingly, in this IDF this time, there was a study regarding how do these GLP-1s and we have the other amylins, how do they work? So there have been various theories initially that they probably change your metabolic rate or whatever. But as it boils down to just one thing, it reduces portion size and changes food seeking behavior. That are the only 2 things that it does. As far as the central nervous system is concerned, we have other drugs for that, phenterabine and we have the topiramate. They are the ones which are to be used to reduce weight, or propranolol. They are the one which act centrally. But having said that, if you use semaglutide or any GLP-1 for 1 year, full 1 year, the brain level of weight is low set automatically. After a year, you stop it and the patient will have low portions and will not have food seeking behavior. That is change of behavior through peripheral means. That is another thing, body adapts to the situation.
It's used in pediatrics.
What?
Use of semaglutide in pediatrics, obese children.
Well, in young children it is not recommended. You can use it above 12 years of age, not in pediatric population.
अभी आपने टर्मिनोलॉजी वहाँ पे यूज हुई है, हंग्री ब्रेन और हंग्री
Gut.
हंग्री कैट। why we are using semaglutide in the advanced stage? Why we are not controlling the hungry brain here? ताकि वो हमारा जो patient है वो
Got your
जाए
point.
ना।
Got your point. That is what I meant when I was saying that we have to have good patient selection. GLP-1 अमृत धारा नहीं है. You cannot give it to every patient for weight loss. In a patient of hungry brain, I mentioned 2 other drugs. They are for that purpose. That a combination of 2 drugs. It is approved by FDA. You can use it. Even propanol is also approved. Phentermine is not available in Pakistan, but propanol is available. But then they have other problems with that, associated with that. Like you feel heat with topiramate, you feel heat, and then you have kidney stone propensity. The patient may get it. Interesting कि बात से बात अगर निकलती है तो there is a third method of weight gain also that I did not mention because it affects a certain number of population and it is still in the development stage. That is related to gut flora. There are leaning bacteria and there are fattening bacteria in your large intestine. And basically those bacteria you cannot change. You kill them with antibiotics. इस पे बड़ी interesting study थी. You kill them with any antibiotic, it will come back. Same type will come back, no matter which area of the world you are in. The study was conducted in Holland, and they found very interesting things with this. There were certain bacteria which were converting sugars into alcohol in large intestine, and those people were developing fatty livers without even drinking, and developing cirrhosis without even drinking. So इसी तरह, and they tried to change it, but same thing happened. They had done it actually transgenetic study. They had people from South Asia, people from Central Asia, people from Europe, Caucasians, blacks, everybody. And they have been living in Holland for last 10 to 12 years. Some of them were second generation. But they all had same flora in their gut as that of their native people. And they couldn't change it.
They are using the same food addition from their
Same food? No. They were not using the same food types. Even then, bacteria strains are related to your genetics. They will remain the same across a certain genotype pool. They will remain the same. Similarly, another point that I did not mention in this, and it is worth highlighting, there are other type of obesities which do not respond to these measures. There is like genetic obesities, in which there are various syndromes. I mentioned one, Prader-Willi syndrome, but there are others. And then we have sarcopenic obesity. Now, if you give semaglutide to a sarcopenic obesity patient, the patient will go in shock and may die, because they do not have that amount of muscle to be activated by insulin, and their dose will go to those places which where it will go oversensitive to insulin, and the patient may go in shock. Exactly. So these are the people. You have to see what type of obesity is there. There are phenotypes, 2 main phenotypes. There is android and gynecoid. There are 2 types of obesity, generally speaking. Android is male type of obesity, more fat around abdomen. Then we have gynecoid obesity, the more fat on thighs, hips, and pelvic area. So there is a difference. Gynecoid obesity does not give rise to metabolic changes to that extent, whereas android obesity is related with metabolic problems. Then we have sarcopenic obesity, as I mentioned, and then we have those obesities which are genetically related. Then we have thrift genes. It's such a vast pool of classes. We are actually just encountering it now. Now we are addressing it as a problem now. Any more questions? Yes, sir.
सर मेरा क्वेश्चन गाइनी से रिलेटेड है कि हम पीसीओडीज के काफ़ी सारे पेशेंट्स डील करते हैं जिनमें ओबेसिटी एक प्रॉब्लम है. सम आर with diabetes and some are non-diabetic, उनमें एक इनका रोल बताएं और some contraindicated conditions जिसमें ये ड्रग हम नहीं ले सकते, उसको थोड़ा हाईलाइट करें, स्पेशली रिलेटेड टू थायराइड.
Related to thyroid?
Yeah. If patient is hypothyroid or hyperthyroid, is this drug is recommended or not?
Yes, thank you. Actually, first part of question is use of GLP-1s in PCOS. It is recommended. There is evidence also. I did not mention it here because it was not metabolic, but recent studies that I have read myself about a week back, very good study showing that PCOS respond very well, rather better than any other drug, those patients. And foremost is that you see there is high androgen levels and there is hormonal imbalance in those patients, and that all hormonal modulation occurs when you give GLP-1s, because all these hormones are related to insulin sensitivity. Once ovaries are sensitive to insulin, most of the problems which stem from PCOS, they are gone. Contraindication is as far as thyroid is concerned, it has got no direct link with hypo or hyperthyroid. They are to be addressed separately as such. If a patient is hypothyroid, so we will see that patient is most probably sarcopenic. If patient is sarcopenic, by sarcopenic I mean they have low muscle mass, and when the patient has got low muscle mass, metabolic rate goes very low and the patient is just fat, and no matter how much GLP-1 you give, patient will not reduce in weight. These patients, as far as the thyroid system is concerned, thyroid is to be addressed ideally separate, and GLP-1s are to be kept separately from that, but there is no contraindication regarding the use unless it is a normal type of obesity. You can use it. Bas, that's it. Thank you very much.
अभी ये कहते हैं कि डॉक्टर अपना पर्सनल एक्सपीरियंस शेयर करना चाहता हूँ सेमाग्लूटाइड के बारे में, तो किसी ने किसी पेशेंट को यूज़ करवाया है तो वो अपना पर्सनल एक्सपीरियंस शेयर कर सकते हैं. अस्सलाम वालेकुम.
ये अभी तलत साहब ने जो शेयर किया है कि 2024 में सिर्फ 66,000 लोग जो हैं वो इसको यूज़ कर रहे हैं, जबकि इंडिकेशन जो है वो अबाउट 15 मिलियन पीपल को है. तो इनके पास कोई ये जो लास्ट 6 मंथ्स गुजरे हैं, क्योंकि अब जो पाकिस्तान में ये अफोर्डेबल प्राइस में आना शुरू हो गया है, उस पर एक तो कोई डाटा कंपनी के पास हो के लास्ट 6 मंथ्स में कितने % राइज है, क्योंकि हम तो इसको तलत साहब की भी प्रेस्क्रिप्शन बहुत आ रही है, हम सारे भी शेयर कर रहे हैं, लिख रहे हैं. एक तो इस पर कोई डाटा हो कि कितना अब लोगों ने इसको ओन कर लिया है, और दूसरा साइड इफेक्ट्स के हवाले से किसी ने बात की थी, तो इसके जो GLP-1 है हर वाकई इसके मेन जो साइड इफेक्ट्स हैं वो तो GI रिलेटेड ही हैं. उस पर मोस्टली यही है, एनोरेक्सिया है, एपिगैस्ट्रिक पेन बड़ी सीवियर है, एपिगैस्ट्रिक बर्निंग है, गर्ड जो है वो बड़ा इसमें कॉमन है, क्योंकि हम बहुत सारे पेशेंट्स को मैच के पेशेंट्स हमारे पास हैं उनको हम एड्रेस करते हैं, तो उसमें बड़े ड्रामेटिक इसके रिजल्ट्स हैं. एक तो सिर्फ मैं ये पूछना चाह रहा हूँ कि लोगों ने मतलब 66,000 जो है वो कितना लास्ट 6 मंथ्स में डाटा इन्हांस हुआ. दूसरा फ्रीनल बाबी ने जिक्र किया कि थायराइड, हाइपोथायराइड, हाइपरथायराइडिज्म में वो मेरे ख्याल इसको मिक्स कर रही है रोजमेट्रिनॉम के साथ, तो जो थायराइड बाइंडिंग को जो है, तो ये तो सेफ है, कैन बी गिवन इन हाइपोथायराइडिज्म एंड हाइपरथायराइडिज्म. और PCOS और हार्मोनल जो अगर प्रॉब्लम्स हैं उसको एड्रेस करने के बाद इसकी में ये शानदार है. थैंक यू.
ओके सर, अस्सलाम
वालेकुम. थैंक यू वेरी मच सर फॉर सच अ नाइस क्वेश्चन, बिकॉज इस बार पहली दफ़ा होगा था ये जो पाकिस्तान मेडिकल जर्नल का 2025 का एडिशन है वो भी पब्लिश नहीं हुआ. इस ईयर का जब वो एडिशन आ जाएगा देन वी विल डिस्क्लोज विद द डॉक्टर्स कि अब कितने परसेंट लोग जो हैं जो आर लिविंग विद डायबिटी कितने नंबर्स इंप्रूव हुए हैं। बिकॉज डॉक्टर्स की तरफ से ही एक सबसे बड़ा कमेंट आया था कि ये डाटा तब का है जब बायोसिमिलर्स लॉन्च नहीं हुए थे लास्ट ईयर एंड से 3 कंपनीज ये ले हैं प्रोडक्ट्स जिसमें से सेमिग्लुटाइड का ओनली डाटा बेस्ड बायोसिमिलर अवेलेबल। तो इंशाल्लाह इस ईयर एंड तक जब पाकिस्तान मेडिकल जर्नल का एडिशन आएगा तो उसमें हम डिस्क्लोज कर सकेंगे कि करंटली कितने लोग जो हैं वो 66,000 से नंबर इंक्रीज हुए हैं जो अब यूज़ कर रहे हैं GLP-1s।
डॉक्टर तनत की तरफ से एक मेडिसिन राइटर मैं बैठा हूँ। तो फीडा का एक क्वेश्चन था ना, पेशेंट हाइपोथायराइड होते हैं, उनको हाइपोथायराइडिज्म की वजह से काफ़ी वेट उन्होंने पूरा किया होता है। उनको अगर हाइपोथायराइड आप ट्रीट कर दें तो उनको उससे भी काफ़ी हद तक वजन लूज हो जाता है। तो मेरा ख्याल है कि GLP-1 एडमिनिस्ट्रेशन करके आपको उनका हाइपोथायराइड लाजमी ट्रीट करना चाहिए। दूसरा जो मॉडर्नली थायराइड CA के पेशेंट होते हैं उनके अंदर GLP-1 जो है वो कॉन्ट्राइंडिकेशन है। इसकी सिर्फ एक ही कॉन्ट्राइंडिकेशन है, अगर कोई नोन है CA थायराइड का पेशेंट उसमें आपने नहीं लेना। और आसान लफ्ज़ों में GLP-1 एगोनिस्ट जो है वो एंटी ओवर कंजप्शन हार्मोन है। जो बंदा ज़्यादा खाता है उसकी भूख कम हो जाती है, जिसकी शुगर ज़्यादा है उसकी शुगर कम हो जाती है, उनका ब्लड प्रेशर ज़्यादा है उनका ब्लड प्रेशर कम हो जाता है। और एक रिसेंटली मैंने पढ़ा बड़ी एक न्यूज़ और द मेल डॉक्टर्स वो खवातीन जो शॉपिंग ज़्यादा करती हैं तो GLP एगोनिस्ट लेने के बाद वो शॉपिंग भी कम करनी शुरू कर देते हैं। थैंक यू।
ये मेटाबॉलिक कार्सिनोमा थायराइड एक्चुअली इसलिए कॉन्ट्राइंडिकेटेड है इसमें कि एनिमल्स में नॉन ह्यूमन स्टडीज में इंसिडेंस ऑफ मेटाबॉलिक कार्सिनोमा थायराइड इंक्रीज हो गया था जब ट्रायल्स हुए थे और ये सारे ओबेसिटी पे थे। ओबेसिटी के जब यूज किया गया तो मेटाबॉलिक कार्सिनोमा थायराइड एनिमल्स में बहुत ज़्यादा हुआ था, लेकिन ह्यूमन में एविडेंस नहीं। एक जब तक उन्होंने कहा हुआ है कि मेटाबॉलिक कार्सिनोमा थायराइड है वो और फैमिलीज में उतना यूज करें और मेटाबॉलिक कार्सिनोमा के साथ हाइपोथायराइड नहीं होता। थैंक यू।